So the next question would be high arched palate. I'm sure you did address about this, but a little bit more details on why it's important how the palate is placed. The high arched palate, or in a layman's term, the upper jaw when it's narrow and pushed towards the nose, and its role in snoring and sleep disordered breathing.
Yeah. So the top jaw is the roof of the mouth. So when we look inside the mouth, we can see the shape of the top jaw. And it should be nice and what we call broad and relatively flat. If it's elevated and pushed inwards, then it forms an arch shape. And that can be a U shape, but sometimes it's a V shape when you look at it. So when that's the case, those sorts of findings raise concerns as to what is the rest of the jaw structure like? And then, as we've alluded to, what is the rest of the breathing like? Because if the jaw is sitting high and narrow, well, the nose sits above that. So the space within the nose can be compromised because of the fighting of space that we're talking about. So the finding of a high, narrow palate, which can have a multitude of causes, again raises a red flag in terms of what is the breathing like, particularly through the nasal passages.
Thank you. That was really an important point, that as dentists, we should note that we see a high arch palate and we don't see crooked teeth or crowding, or we see the alignment is aesthetically fine. It's something that's not to be discharged, but you need to look into the function of the child, especially breathing. Is adenoid and tonsillectomy the first line of treatment for snoring? What would be your take on orofacial myofunctional therapy?
Okay. There's probably three questions rolled into one there. So the first thing is that the removal of tonsils and adenoids historically is first-line treatment, and it is still the first-line treatment, but there's a few qualifications I think we need to add to that statement in this day and age of knowledge. So if a child has snoring, sleep-disordered breathing, the most common cause for that is enlargement of the tonsils and adenoids. And there could be other things going on, but the most common consistent finding is enlarged tonsils or adenoids. So in those children, if the compromise and obstruction is significant, then yes, the removal of those is first line, absolutely. But if they're not big tonsils and they're not big adenoids, then removing them is not going to improve the airway. So if their problem is skeletal deficiency, then their management is dental and orthodontic. Tied in and mixed in with this is the way that the muscles around the jaw, the throat, and the neck actually form into compensation patterns to get around problems. So, for example, if you have big tonsils and it's hard to swallow, so you will use more of your accessory muscles to force the swallow. So that's a compensation. And some of these things can actually be a compromise to the breathing and the sleep. So when we deal with these problems, it's not just a matter of getting it unblocked, but it goes back to, like I used the broken leg example. We need to fix the fracture. That needs to come first, but then we need to do the rehabilitation to get the function falling back into line again. So, which is where the myofunctional therapy falls into that equation. For those that are, again, not familiar with the terminology, myo means muscle, function means function. So this is muscle function. And there are different types of myofunctional therapy. And this is where it gets confusing when you start to talk to different people. Because in a dental point of view, the myofunctional therapy is in the context of orthodontics.
Yeah.
But there is myofunctional therapy for swallowing, there's myofunctional therapy for speech, and there's myofunctional therapy for sleep and breathing. So even though we call it myofunctional therapy, we actually need to be a little bit more sophisticated and say, with regards to what element of the function are we addressing and helping. And sometimes, it's a combination of everything. It's not like there's lines in the sand that separate these out from each other.
Makes a lot of sense. So for those of the dentists who are listening to this, there's a lot more to myofunctional therapy than just a couple of days over the weekend training. just not about the dental point of view. And when we have to look into airway, there's much more learning that we have to do. Thanks for pointing that out, Dr. David. Can you please enlighten us about the role of deviated nasal septum? We did speak about it, but then we want to learn about high arch palate and deviated nasal septum. And then will an arch expansion also play a role in nasal septum correction if we start early? Say we have a child that's 8 or 9 year old, and then we see a deviated nasal septum, and if we're going to expand the jaws, what would the effect of this be on the septal deviation?
Yeah. So again, just for the benefit of everybody, so the middle partition of the nose is called the septum, and it's made of bone and cartilage. And when it's not straight, we call it a deviated septum. Now, the problem that we have is that the understanding of why we get a deviated septum in the first place. So the one that we do know for sure, no problems at all, was trauma. So any sort of physical trauma that pushes on the septum and pushes it out of alignment, that one's easy, and that makes sense. What's interesting is if we do fetal ultrasound, so ultrasounds of fetuses as they're growing and developing, up to 15% of those will have a deviated septum that we can pick up on the ultrasound. Now, it's very unusual that they would have any trauma that would have caused that. And when we look at babies when they're born, there's a group of babies that also have deviated septum. So in the fetal ultrasound, some of those deviated septums seem to sort themselves out. But in babies that are born, there's roughly 3 to 5% at birth that have a deviated septum. So the septum seems to be able to move around a fair bit in the sort of normal growth and development stages in utero, but in the mainstay is relatively straight for most people. The question then, the challenge we have that nobody has done the research on, if we're going to be honest, and it'd be difficult research to do if we're going to be honest and fair too, is to monitor what a normal septum does over the growth of somebody's lifetime. We don't have a series where people have taken 1,000 children and looked inside their nose every 6 months and give the parents a questionnaire to ask about trauma and to document what the septum looks like and clarify any breathing problems. We just don't have that information. So the problem that we have is that we're looking at an end product. And the end product is that, for example, we're looking at jaw and teeth problems, and we notice that the septum is crooked, and then it becomes, as you asked the question before, the chicken and the egg.
Yeah.
Was it something that went wrong with the craniofacial form and development that also compromised the septum? Or was it the compromised septum that compromised the breathing, that compromised the craniofacial growth, and so forth? So again, we don't have a good answer to know for sure. There's the suggestion that the high arched palate, because it's high, squashes on the nose and then the nose buckles, and hence the deviation. It's an interesting theory, but again, it's not one that's proven or established. Then the next bit that you asked about was, well, what about expansion? So
Yes.
if we expand the jaw, open the jaw, bring the palate down, will that straighten the septum? Now, the reason that became of interest was there's a paper that was published a long time ago now, before we had CT scanning.
Okay.
So we had plain film X-ray, where they published results showing the septum going straight. The problem is that research was terrible research, because the X-ray that we're using to compare the before and afters weren't actually in the same part of the nose. So the front of the nose is more prone to being crooked, and the back of the nose is more likely to be straight. And their before pictures were the front of the nose, and their after pictures were the back of the nose. And they were claiming that the intervention had straightened the septum. So that was clearly, false advertising in terms of their results. But you need to know what you're looking at. So what people have done is they've said, well, we've got the CBCTs now. Now, to my knowledge, there's only one paper that's ever been published where they've done it with a CBCT before and after, and it did show that the septum does straighten to some degree. The important thing too is we've got to be very careful, because there is a whole range of different types of septal deviations. Yeah. So I think when it comes to a septal deviation, if it's part of the dental management plan and it's hoped that the septum will correct as part of that, that's certainly something that's excellent to look forward to, but it's something that needs to be monitored and assessed by an ENT to make sure that actually does happen.
There's something really good to note about. I know this was not part of the interview, but then now I'm really interested or inquisitive to know about the anterior septal deviation and the posterior. So we as dentists, we could probably make out a septal deviation only when there's a facial asymmetry, which is obvious.
Yeah.
So how often do we see a posterior nasal septum deviation as well? And what is the role of a narrow high arch palate on the posterior septal deviation as well?
Yeah. So again, that's where we have a problem because we're making these observations and we are looking at the end product. But
Okay.
you know, we basically, it's like looking at a car accident. We can see that there's been a crash, but we don't know exactly what the circumstances were that led to that crash. Did the person fall asleep behind the wheel? Were they drunk? Was somebody going too fast? You know, so what we've got is the end product of a whole sequence of events that we haven't actually really got a good handle on at the moment. But in terms of what you asked me about, the anterior and the posterior, with the advent of what we call CBCT, which stands for cone beam CAT scan tomography, computerized tomography, we can look at the septum as part of the orthodontic planning, for example. It just happens to be there. It's just opportune. But it's also important for people to realize that CBCT often will miss the anterior deviations because it's cartilage. It doesn't show up as well on a scan as what bone does. So we will miss a lot of anterior septal deviations on a scan because being cartilage, they just don't show up as well. So you can have an anterior septal deviation that you don't even appreciate is there because it doesn't show clinically and it, you know, in terms of the outside. And it also doesn't show up radiologically either. So again, just wanting to highlight where the physical exam looking inside the nose by the ENT is actually, of all the options, is the most reliable.
That really, so we do have to work as a team is what I understand. The entire purpose
Absolutely.
of this session was to help the dentist out there understand that it's a team effort and it's really important we put in all the pieces of the puzzle together before we go on to start treating the children. Having said that, we have one question here that says, what is the right age to correct septal deviation? I would be interested with this question as well because the ENTs that we speak to or we try to refer, they usually say wait until like 18 or 19 till the child grows and then correct it. But then when it's pediatrics, we don't want the child to be waiting that long and suffer. So how is that? What is the suggestion?
Yep. So I think we need to realize that this is a very controversial topic amongst ENTs. And I've been at conferences where ENTs are, you know, arguing over this. And the arguments center on a bit of historical research where in animal models, to sort of try and work out what happens, is they went and did nasal and septal surgery to look at what happened to the development of the nose. And the animal model in particular they used was pigs. And what they did is they basically removed the septum to see what would happen to the snout, and it didn't develop very well. So then the conclusion was if you operate on the nose, it won't grow and develop properly.
Okay.
So that was the starting point. They sort of said, oh, you never touch it. The nose has the bone and the cartilage interfaces, or what we call growth plates. And the concern is if you interfere with those growth plates and as it's growing and developing, then the nose won't develop properly. So that's the history. In about 2011, people started to publish their results of operating on pediatric nasal septal deviations. And they were showing that it was not having any adverse effect. And it's an interesting situation because the concern is that operating on the nasal septum will impact on nasal growth and development. But having a nasal septal deviation has an impact on facial bone growth and development.
And breathing as well.
Yeah, and breathing and sleep and everything. So I would just make people aware that the teaching is, in the mainstay, traditionally, do not operate on children's septums. That is the traditional accepted teaching, and no one should be criticized for adopting that philosophy because that's not unreasonable. But at the same time, I would encourage people to look at the scientific research and the publications that show it is actually possible. And I have been doing it since my pediatric training in 2006, so for nearly, let's say, 15 years. I operate on pediatric nasal septal problems, and I haven't encountered any problems that I can think of that come to mind that would make me concerned about the procedure, as long as it is done in a sensible and conservative manner, and it's done for appropriate reasons, and in particular to help a child breathe and sleep properly at night.
So what's the youngest age group that you have treated, Dr. David, for nasal septal deviation?
A 4-year-old, 4 years of age.
That's something that's really a take home for me today. So the next time we refer.
And the other interesting too, that if I may just point out as well, is that we talked about deviated septums in infants. One of the groups that's at high risk of septal deviation are children that are born prematurely, and they have nasal tubes put down to help them breathe or for feeding. In some centres, because they've identified that this is a risk for causing a septal deviation, those babies are then assessed at about 6 months of age, 12 months of age for a septal deviation. And if it is showing signs of being crooked and hasn't straightened up, they will actually do what's called a septal manipulation under an anaesthetic to actually straighten it up in those babies. Now, in my country, in Australia, that's not something that's done as part of the routine assessment, but in parts of the United States, that is part of their management plan of premature babies.
And as a pediatric dentist who's focused on prevention, deviated nasal septum interferes with the treatment planning as such. You know, it's just not about aligning teeth. We'll have to get those children breathe through their nose, and if that doesn't happen, we have repeated failures. You straighten them up and then they collapse again. You straighten them up and they collapse again. So it's really important for establishing breathing, and for the doctors who are here or for the parents who are here, you need attention for deviated nasal septum, and wait and watch is not the answer for the same. Thank you so much for Dr. David for having taken time out.
It's been a real pleasure, and apologies for all the technology, but we got there in the end.